Patient's here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
in your left
hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Okay, I want you to close your eyes for a second. Just picture a scenario. It's 2 a.m, you're in the emergency department.
Right. The worst time.
A worst time. And you're looking at this 4-year-old girl. Let's just call her Emma. She's just been brought in after taking a really nasty fall off a playground slide.
So we're dealing with a potential head injury, likely a concussion, maybe even worse, the classic presentation.
Exactly. But here's the thing. I want you to try to see the scene through her eyes. Her head is just throbbing. She's dizzy. She feels like she's going to be sick.
Mm-hmm.
And she's been dragged out of her safe, warm bed into this place with blindingly bright lights. It's cold, and it smells like rubbing alcohol and bleach.
All of her senses are on high alert. It's a total sensory assault.
A total assault. And she's surrounded by strangers in masks who are all moving really fast and talking really loud.
It's the absolute classic pediatric nightmare. And if we're talking physiology, her cortisol is just spiking. It's through the roof.
So for a child like Emma, the physical pain of the fall it's actually fighting for bandwidth with the sheer psychological terror of the environment itself.
That's a perfect way to put it. The environment is as much of a threat as the injury in that moment.
Right. And then the admission nurse walks in. Now, this nurse is, let's say, clinically brilliant. She can calculate a weight-based medication dose in her sleep. She hits the vein on the first try every single time.
A total pro on paper.
Total pro. But she walks in, ignores Emma completely, looks straight at the mom, and says, "We need to put her on a stretcher, shoot some dye into her arm, and then put her to sleep for a test."
Oh, no.
Yeah.
And just like that, with one sentence, despite all that incredible clinical skill, you've completely lost the patient.
You've lost the patient and you haven't even touched her yet. To an adult, that sentence is a coherent care plan. It makes sense.
It's just information.
But to 4-year-old Emma,
Yeah.
she just heard, "We're going to stretch your body on a medieval rack, shoot you with a gun, put death in your veins, and then kill you like we did the family dog."
And it sounds dramatic to us saying it like that, but that is literally word for word how a preschooler's brain processes those specific words.
Is it terrifying?
It is. And
Yeah.
that disconnect, that gap between our clinical efficiency and the child's lived reality, that is exactly why we are dedicating this entire deep dive to Chapter 8, Atraumatic Care of Children and Families.
Welcome back to the deep dive. Today we are unpacking atraumatic care. And I want to be really clear right off the bat because I know we have a lot of serious learners, nurses, and medical pros listening. This isn't the soft skills episode.
No, not at all. And that's probably the most common misconception we see in the source material, isn't it?
I think so.
People hear atraumatic care and they immediately think it's just, about handing out stickers or wearing a scrub top with cartoon characters on it.
Right, the fluff.
But when you actually dig into the text, you realize, no, this is a core clinical competency. This is about safety, period.
It's about the philosophy of do no harm. But what we're doing here is we're expanding the definition of harm.
Exactly. Do no harm isn't just about not cutting the wrong artery or giving the wrong medication. It's so much bigger.
So what does it include?
Well, if you cannot get a child to cooperate without traumatizing them, you risk physical injury during procedures. A child flailing around is a real danger.
Sure, you could miss with a needle, cause more damage.
You could get inaccurate vital signs because their heart rate is 160 from pure panic, not from their medical condition. And, maybe most importantly, you risk this long-term psychological scarring that makes them fear healthcare for the rest of their lives.
You're creating a phobia.
You're creating a patient who will avoid going to the doctor as an adult because what happened when they were 4.
Wow. So our mission today is to really break down the framework for doing this right. We are going to master atraumatic care. We've got the core philosophy. The text calls it the 3 pillars.
Right.
We also have a list of forbidden words from the text that, I'm not kidding, it legitimately blew my mind.
The do not say list. It's a game changer when you see it.
Yeah. And then we have the developmental hacks, how to basically game the system for every single age group, from tiny infants all the way up to teenagers.
Plus, and we can't forget this, we need to talk about the parents. Because in pediatrics, you never, ever have just one patient.
You always have 2 or 3 or more.
You always have a family system in that room.
Okay, let's start at the very top, the definition. How does the source material define atraumatic care?
It defines it as therapeutic care that minimizes or eliminates psychological and physical distress.
It sounds so simple when you put it like that.
It does. But it implies something pretty heavy, which is that standard medical care, by its very nature, is inherently traumatic.
You know, I'd never thought about it like that, but it's true.
It is. I mean, think about it objectively for a second. We strip people of their clothes, we separate them from their routine and their home, we poke them with sharp objects.
We invade their privacy, their personal space.
We force them to lie still in these strange, sterile environments. For a child, that's the definition of trauma. So the goal of this framework is to strip away all the preventable trauma so that the actual healing can happen.
Okay, so the text outlines these 3 pillars or principles. If I'm a student taking notes right now or a nurse trying to audit my own practice, what are the big 3 I need to write down?
The first pillar, the big one, is prevent or minimize physical stressors.
Okay, so that seems like the obvious one. We're talking pain management.
Pain is the headline, for sure. That's what everyone thinks of first. And we use things like numbing creams, lidocaine or those little buzzy bee devices to distract the nerves.
I've seen those. They vibrate and have an ice pack.
Exactly. But the text actually goes much broader than just pain. It includes things like sleeplessness, immemoriality, and the inability to eat or drink.
So being MPO, nothing by mouth.
Imagine being a 2-year-old who is MPO for 6 hours before a procedure. You can't explain it to them. They don't understand why you're withholding food and water.
So the kid isn't being bad or throwing a tantrum for no reason.
No. They're starving and confused and scared. That is a profound physical stressor that almost always leads to a behavioral meltdown. And we label the kid difficult when we created the situation.
That makes so much sense. Okay, under this physical pillar, there's a specific intervention the text highlights that I think we need to spend some real time on. It's called therapeutic hugging.
Yes. Therapeutic hugging.
I have to be honest, when I first read that, it sounds like something you'd pay extra for at a wellness retreat.
Right. It sounds a little bit out there. But in a clinical setting, this is a very specific technical term.
And it's defined in direct contrast to what?
To restraint. In the old days, and honestly in some facilities that are still behind the times, if a child needed a procedure, like an IV start or a lumbar puncture, the standard practice was just brute force.
We hold them down.
You hold them down, you pin their limbs to the bed, maybe 2 or 3 people holding the small child down.
Which, I can only imagine, triggers an immediate panic response.
A massive panic response. You're talking full-blown fight or flight. You are physically overpowering a child who is already terrified.
It feels like an assault.
It is. I mean, technically, it creates compliance because they physically can't move, but it creates this massive psychological injury. It teaches the child deep in their core that the hospital is a place where they are helpless and overpowered.
Okay, so how does therapeutic hugging flip the script? How does it actually work mechanically? If I'm the nurse, what am I asking the parent to do?
You are using a secure but comfortable holding position. So usually this is something like chest to chest, or with the child sitting on the parent's lap facing forward.
So they're contained, but they feel connected to their parent.
Exactly. The parent's arms embrace the child, securing the child's arms and maybe even their legs between the parent's legs, but it feels like a hug. It's firm, but it's comforting. The text really emphasizes that this provides both comfort and safety.
So you're not just letting them run wild. You still need the arm to be still for the needle, for example.
Correct. You absolutely cannot have a moving target for an IV or an injection. That's dangerous for everyone involved.
Yeah.
But with therapeutic hugging, the child is anchored by their safe person.
They aren't pinned to a cold, hard table by strangers?
No, they're pressed against mom or dad. They can feel their breathing, maybe smell their scent. It lowers the heart rate, lowers the cortisol. It changes the entire experience.
Okay, but I have to play devil's advocate here. What if the parent is really squeamish? What if the dad looks like he's going to pass out if he even sees a needle?
Yeah.
Or what if the parent is so anxious themselves that they're actually making the kid worse?
That is a very, very valid concern, and it's a common NCLEX trap question. The text is clear. Use the parent whenever possible. They are your first and best choice.
But not always.
But you have to assess the parent. The parent says, I just can't do this. Or if you see them getting pale and hyperventilating, you have to respect that. You don't want a fainting parent on the floor. Now you have two patients.
So what's the backup plan?
In that case, you get another staff member, another nurse, a tech, someone the child has maybe built a little rapport with, and that person performs the therapeutic hug. The goal is always to avoid mechanical restraints, straps, boards, unless it is absolutely strictly necessary for safety.
So the hierarchy is clear. It's parent hugs first.
Then staff hugs.
And only then, as a last resort, do we even look at restraints.
Exactly. It's all about the least restrictive, most humane environment possible.
Okay, that's pillar 1, physical stressors. What's pillar 2?
Pillar 2 is prevent or minimize separation. And this is huge.
From the parents.
From the parents, from the primary caregivers. For a child, especially a child under the age of, say, 5, the parent is their external hard drive for coping.
I love that analogy. The parent is the external hard drive.
They do not have the internal software yet to handle significant stress on their own. They literally borrow the parent's calm.
So if you separate them, you are effectively removing their ability to process the event.
You are. If you take the parent away, the child's system crashes. It just goes into overload. So that old school rule of parents need to go to the waiting room while we work because they just get in the way.
That's completely out.
It is completely out. The text is very, very clear on this. Promote family-centered care at all times.
So you're treating the family as the unit of care, not just the child.
You have to. You keep parents close. You respect their preferences. The evidence actually supports letting parents stay, even for things like resuscitations or invasive procedures, if they want to.
Really? Even for something that intense?
Yes. It actually helps the parents process the situation because they can see that everything possible is being done for their child. And for the child, just hearing a familiar voice, even if they're not fully conscious, can be calming.
It makes perfect sense. The nurses change shifts every 12 hours. The doctors rotate. The parent is the only constant anchor in that room.
They are the anchor.
And if you remove the anchor, the ship just drifts.
Beautifully put. And that leads us directly into pillar 3, which is promote a sense of control.
This one is really interesting to me because, let's be honest, being a patient means losing almost all control.
Sure.
You wear the gown we give you, you eat the Jell-O we give you, you wake up when we tell you to wake up for vitals. How on earth do you give control to a 4-year-old without creating total chaos? You can't let them dictate the medical plan.
No, of course not. That's not what it means. It means you give them choices. But, and this is probably the most critical distinction in the entire chapter when it comes to behavior management, you must give them valid choices.
Okay, define an invalid choice for me. What does that look like?
An invalid choice is walking into the room with a syringe in your hand and asking the toddler, can I give you this shot now?
Right, because the answer is always, 100% of the time, no.
The answer is always no. And then what do you have to do? You have to do it anyway.
So now you've lied to them.
You've lied. You pretended they had a choice, they exercised that choice, and you immediately overruled them. You just broke all trust. You taught them that their voice doesn't matter and that you are not a truthful person.
So what's the valid choice in that exact scenario? How do we reframe that?
A valid choice controls the environment or the method, not the necessity of the medical procedure. The procedure is non-negotiable.
Okay, so give me an example.
You say, it is time for your medicine. That part isn't a choice. You're honest and direct. But do you want the red Band-Aid or the blue Band-Aid afterwards?
Ah, so you're letting them control the parameters.
The parameters. Do you want to sit on mommy's lap or hold your teddy bear while we do it? Do you want the medicine in your left leg or your right leg?
It seems like such a small thing to us as adults.
It's tiny to us. But for a child who feels completely powerless, that little bit of agency is everything. It grammatically reduces the feeling of helplessness. The text calls this empowering the child.
Even something like letting them play with the stethoscope or the blood pressure cuff beforehand.
Absolutely. That's a perfect example. You demystify the equipment. You turn a scary object into a toy. It gives them a sense of ownership and familiarity.
Speaking of demystifying, I really want to pivot to the section of the text that I found the most jarring and honestly the most impactful, the communication section. Specifically, the table in there, the bad words list.
Ah, yes. Table 8.2 in the source. Alternatives for confusing or misunderstood terms.
I read this table and I literally gasped out loud Because these are words we use every single day as adults. They are standard medical vernacular.
They are.
But when you look at them through the lens of a literal-minded child, my gosh, it's a horror movie script.
It really is. We have to constantly remind ourselves that children, especially preschoolers, like our Emma, are incredibly literal thinkers. They don't get nuance, they don't get metaphor or professional jargon.
They interpret language based on their very limited life experience.
Exactly. And their life experience is, oh, it's pretty small.
Let's just run through a few of these because I think it's so important. We already mentioned put to sleep in our intro.
The classic trap, we say it all the time for anesthesia. The doctor's going to put you to sleep now.
And the child's reference point for put to sleep is...
It's often Buster, the family's 14-year-old golden retriever, who went to the vet last year to be put to sleep and never came back.
So they think you were euthanizing them. That is just heartbreaking.
It is. They interpret it as death. They think they're being sent away forever and they won't wake up. So the text suggests saying something like special sleep.
Special sleep.
Or a special medicine to help you take a nap until the doctor is all done. You have to explicitly clarify that they will wake up afterwards.
That feels like the most crucial addition. And then you will wake up.
You have to close the loop for them.
Okay, next one from the list. Dye. As in contrast dye for a CT scan.
This is a purely auditory issue. To a child's ear, dye sounds exactly like dye.
D-I-E.
Yep. So you're walking in and cheerfully saying, "Hi, I'm going to put some dye in your veins now." And the child hears, "I'm going to put death in your veins."
That is absolutely terrifying. Why would any child agree to that?
Exactly. If a giant stranger in a mask told you they were about to inject you with death, you'd fight for your life. And that's what they do.
So what's the alternative?
You make it functional. You explain what it does, not what it is. So you say, this is some special medicine to help the doctor see pictures inside your tummy.
Simple. Makes sense. Okay, stretcher. We say this 50 times a shift. Let's move him to the stretcher.
Stretcher sounds like an action verb, like you were going to stretch her.
Like a medieval torture rack.
That's exactly what they picture, that their body's going to be pulled apart.
No, don't stretch me. I can just hear a kid screaming that in the ER.
It happens all the time. Instead, the text says to call it a rolling bed or a bed on wheels. Simple, literal, non-threatening.
How about the word shot?
Shot implies violence. It's an aggressive word. They think of guns, of being shot.
So what do we say instead?
The text recommends medicine under the skin.
That feels a little bit wordy, though, doesn't it? I need to give you some medicine under your skin.
It is wordy, but what it is accurate and neutral. You've removed the violence from the word. Or even a quick poke.
That's better. A quick pinch.
Another one that tricks people up constantly is using clinical words for bodily functions, like stool.
Stool, as in poop.
Yes. If you ask a 4-year-old, have you had any stool today? They're going to look around the room for a small chair. They have no idea what you're asking them.
Or urine.
They hear, urine. It's just confusing. The text gives a great rule of thumb here. Use the child's terminology.
So you have to ask the parents.
You pull the parents aside quietly and you ask, what words do you use at home? Is it pee and poop? Is it caca? Is it number 2? And then you use that exact word with the child.
You're speaking their language. It builds instant rapport. It's like code switching for toddlers.
It is. And there's a general rule that sort of overlays all of this specific vocabulary, which is be honest, but be gentle. The text warns very strictly against ever saying it won't hurt if it's going to hurt.
Because that's the fastest way to lose all trust forever.
It's a one strike and you're out situation. If you lie about the pain, they will never, ever believe another word you say.
So what's the honest but gentle way to say it?
You say, this will feel like a quick pinch, or it's going to hurt for just a second, but then it will be all over. Or you can compare it to something they already know, like a mosquito bite or a little scratch. You give them a frame of reference.
This is so critical. I want to move on to the developmental stages because a conversation with 4-year-old Emma is obviously very different from a conversation with 14-year-old Emma. The text breaks this down by age group, which is super helpful for structuring care. Let's start with the littlest ones, infants.
With infants, you have to remember they are purely sensory creatures. They don't understand your words at all. So atraumatic care for them is all about controlling the environment.
Touch, sight, hearing.
Soft voices, dim lights if possible, minimizing any sudden, jerky movements. But the biggest thing the text mentions for this age group is learning to read their cues. Infants have very subtle stress signals that are often missed by busy staff.
You mean like crying?
Crying is actually the late sign. Crying is the "I've had enough and I'm totally overwhelmed" scream. Long before they start crying, they will give other signals.
Like what? What should I be looking for?
They'll turn their head away from you. They might yawn excessively,
Yeah.
which is often a stress release mechanism, not just a sign of tiredness.
Oh, that's interesting. I didn't know that about yawning.
Yeah, or they might get really irritable or splay their fingers out wide. Those are all signs of overstimulation.
So if a baby is looking away from me and yawning while I'm trying to do an assessment, they aren't bored, they're overwhelmed.
Exactly. They are communicating very clearly in their own language, "I am overstimulated, I need a break right now." And atraumatic care means respecting that pause. Stop the procedure if you can, let the parent soothe them, swaddle them, and then try again once they've had a moment to reset.
Okay, let's move up to toddlers and preschoolers. This seems like by far the hardest group to manage.
It can be, yeah.
They are mobile, they have very strong opinions, they can scream no, but they don't have any real logic yet.
This is the peak concrete thinker stage, but it's also mixed with a heavy dose of magical thinking. And this is the age where the fear of bodily injury and mutilation is at its absolute peak.
Bodily mutilation, that sounds really intense.
It is for them. They have very, very poor body boundaries. So if a toddler gets a small cut, they often believe, genuinely, that all of their insides, all their blood, are going to leak out through that tiny hole.
That's a horrifying thought. So they think they're going to deflate like a balloon.
Essentially, yes. And that's why Band-Aids are practically currency for this age group. A Band-Aid isn't just a cute little covering. For them, it's a magical seal. It keeps their insides in. It fixes the leak. You should never, ever underestimate the power of offering Band-Aid to a 3-year-old.
Wow. Okay, so for this very literal, very scared group, how do we prepare them for a procedure? Do we try to explain the steps?
You keep it incredibly simple, but your number one best tool is play. The text strongly suggests using puppets or dolls as a third-party tool.
So if you need to listen to their heart,
You listen to the doll's heart first. Then you let them use the stethoscope to listen to the doll's heart. You're making the scary, cold object familiar and less threatening.
you're demystifying it through play.
Exactly. And the timing of your explanation is absolutely crucial here. The text has a very specific rule. For toddlers, so say 1 to 3 years old, you tell them about the procedure immediately before it happens.
So you don't tell them in the morning if the shot is happening in the afternoon?
Absolutely not. They have no real concept of future time. If you tell them at 9 a.m. about a shot happening at 2 p.m., you have just given them 5 hours of undefined escalating anxiety. They will just ask, "Is it now? Is it now?" every 5 minutes.
And for preschoolers, like our 4-year-old Emma,
For them, you can prep them maybe an hour before. They can handle a slightly longer window. But you still want to keep that window very, very short.
okay, moving up the ladder to school-age children. So we're talking roughly 6 to 12 years old.
These are your little scientists. This is the age group that wants to know why and how. They are full of questions. Why do I need blood work? How does the X-ray machine see my bones? Will the medicine make me feel weird?
So for this group, this is where you can finally pull out the diagrams and the models.
Diagrams, simple books, short videos. You can even start using correct medical terminology, as long as you explain it in simple terms. They really appreciate being treated like they're smart enough to understand.
And what about the timing for them?
For this group, you can prepare them a few days in advance. They actually benefit from having some time to process the information, think of questions, and mentally prepare themselves.
The text mentions something interesting about their emotional reaction, that they might try to be brave.
Yes, the stoic school-ager. It's a very common phenomenon. They might sit very still and stiff and act like they're totally fine because they don't want to cry and look like a baby.
But inside, they're terrified.
Inside, their heart is pounding, their palms are sweaty, their heart rate is 140. So the key takeaway here is, don't mistake silence for comfort.
You still need to intervene.
You still need to offer comfort and praise them for their bravery, but you also need to check in with them. Validate that it's okay to be scared. You can say something like, "You are being so brave right now, but it's okay to cry if it hurts." You give them permission to release that stress.
And finally, our last group, the adolescents, teenagers.
This is a whole different ballgame, a completely different set of priorities.
Yeah.
The focus here shifts dramatically to privacy, body image, and independence.
And their friends, the peer group.
The peer group is everything. An illness or a hospitalization separates them from their social group, which is their absolute lifeline, so they feel incredibly isolated. They have this massive fear of missing out.
I can imagine the approach to privacy is really tricky. You've got the parents sitting right there in the room.
It is. The text advises that you talk to them like they're adults. Don't use baby talk or condescending language. But you also have to find a way to respect their confidentiality.
So there are times you need to ask the parents to leave.
Yes, there will be times, maybe when you need to ask about sexual history or substance use or mental health, where you need to ask the parents to step out for a few minutes.
That can be such a tense moment. How do you handle that without making the parents feel suspicious or shut out?
You frame it as a standard policy. You can say, it's our hospital's policy to give all our teen patients some private time with the doctor to ask any questions they might be embarrassed to ask in front of their parents. It normalizes it. It makes it not about them personally.
And I noticed the text says you should specifically discuss how their care might affect their appearance.
That is one of their biggest, if not the biggest fear. Will this procedure leave a scar? Will the chemotherapy make me lose my hair? Will the steroids make my face puffy?
And we might see that as vanity, but for them.
For them, it's their entire world. You cannot brush it off. To a 16-year-old, their appearance and how they fit in with their friends is their reality. So you have to address that head on. And honestly, minimizing that concern is itself traumatic.
So we've got the core philosophy, the right language to use, and the age-specific hacks. But let's be realistic. Hospitals are busy places. Nurses are overwhelmed. We can't always do all of this alone.
No, you can't.
The text introduces a specific role that acts as a kind of force multiplier for atraumatic care, the child life specialist.
The CLS. And I cannot stress this enough. The child life specialist is not just the lady who brings the toys.
I feel like that's the common stereotype, right? Oh, child life is here to play Uno with the kids.
It's a massive, massive undervaluation of their role. A CLS is a highly trained professional, they often have a master's degree, who specializes in child development and the psychosocial impact of illness and hospitalization.
So their entire job is to be the expert on this stuff.
Their job is to translate the medical world into the child's world. They are the bridge.
So they're the ones doing that detailed procedural prep with the dolls that we talked about.
Yes. They are the ones with the specialized dolls that can show Emma exactly what the IV will look like and where it will go. They are the ones coaching the parents on the best language to use. They also do things like advocacy for the child and even grief and bereavement support.
The text actually uses the phrase quality benchmark to describe them.
That's such a key line. The American Academy of Pediatrics says that the presence of child life services is an indicator of excellence in pediatric care. So if you're a nurse and you're feeling overwhelmed or you have a particularly difficult procedure coming up,
Call child life.
the text says it clearly. When in doubt, consult the CLS. Use them. They are your absolute best resource.
Let's widen the lens a bit now to the whole family. We talked about family-centered care as one of the pillars, but the text gets into some specific rules here, especially around culture and communication.
Cultural humility is essential. You have to go in with the understanding that you are not the expert on that family's beliefs. You have to respect that different families handle health and illness in very different ways.
Right.
But there is one safety rule in the text regarding communication that is just absolute dynamite. It's about the use of interpreters.
The interpreter rule. This feels like a major NCLEX highlight, a big red flag.
It is a major patient safety standard. So here's the classic scenario. You have a family that doesn't speak English fluently. You have a complex, serious medical diagnosis to explain. But their 10-year-old daughter speaks perfect, fluent English. What do?
The temptation is so obvious. You ask the daughter to translate for her parents. She's right there. It's fast. She knows the context.
And the text says, you must never, ever do that.
Why is it such a hard no? Is it just about the accuracy of the translation?
Well, the accuracy is a huge part of it. It's fundamentally unsafe. A 10-year-old does not have the medical vocabulary to accurately translate hypoglycemia or informed consent. You risk major medical errors because of a simple mistranslation.
Okay, that makes sense from a safety standpoint. But what's the trauma aspect?
You are putting a massive, unfair emotional burden on a child. Imagine making a child be the one to tell their own parent you have cancer or the baby is very, very sick.
Oh, wow. I never thought of it that way.
That is not their job. It creates this terrible role reversal where the child is forced to emotionally care for the parent. You are actively traumatizing that child by forcing them to be the bearer of bad news.
That really puts it in a different perspective. So what is the absolute unbreakable standard of care?
The standard is you always use a trained professional medical interpreter, whether that's in person, over the phone, or on a video service, period.
And when you're using an interpreter, what's the best practice?
Here is the pro tip from the text that really separates the rookies from the pros. When you speak, you look at the family, not at the interpreter.
Right, because you are talking to them. The interpreter is just the tool.
Exactly. You speak in short, simple sentences. You pause to let the interpreter translate. But you keep your eye contact and your body language focused on the patient and the parents. It shows respect and it builds the relationship. If you just stare at the iPad or the interpreter, the family feels completely excluded from their own care.
This brings us to the final piece of this whole puzzle. Education. Because eventually, hopefully, Emma's going to go home, and her parents need to know how to take care of her.
Patient education is where the rubber meets the road. I mean, if we do incredible care in the hospital but send them home confused and scared, they'll just be back in the ER in 24 hours.
But there's a huge problem, right?
There's a huge problem. The text cites a statistic that is just staggering. It says that 45% of Americans have low health literacy.
Nearly half the population.
Nearly half. It means that almost half the people you talk to on any given day might have trouble processing complex health information, reading prescription bottles, or understanding discharge instructions.
And I imagine that stress makes literacy drop even lower.
It absolutely does.
Yeah.
Stress makes us all stupid. When your cortisol is up, your prefrontal cortex, the logical thinking part of your brain, basically shuts down. So a parent who is normally very sharp and on top of things might really struggle when their kid is sick in the hospital.
The text gives us some red flags to watch out for. How can we spot potential low health literacy without making someone feel embarrassed?
You watch for the behavioral cues. If a parent says, "Oh, I forgot my reading glasses at home," when you hand them a form to read.
A classic excuse.
A classic.
Yeah.
Or if they fill out the form, but they leave a lot of it incomplete. Or, and this is the most common one, if they just nod and smile and say, "Okay," to everything you say, but they never ask any questions.
The compliance nod. They don't want to look stupid by admitting they don't understand.
Exactly. They are likely completely overwhelmed or just don't understand, but all the social norms say they should just nod along. So, as a nurse, you cannot assume understanding just because they nodded. You have to verify it.
And the gold standard tool for that is the teach-back method.
This is it. This is the single best tool we have. It is the only way to truly confirm that learning has occurred.
Walk us through how that sounds in a real conversation, because I think a lot of people feel awkward doing it. They feel like they're giving the parent a pop quiz.
It really shouldn't feel like a quiz. The key is how you frame it. So instead of saying, "Do you understand?" which just invites a simple yes or no answer, you put the onus back on yourself.
How do you do that?
You say something like, "I want to make sure that I explain this clearly. Can you tell me in your own words how you are going to give Emma this medicine when you get home?"
That's a really subtle but powerful shift. Make sure I explained it clearly. You aren't testing them, you're testing your own teaching.
Smart, right?
Yeah.
It totally saves face for them. And then if they can't explain it back to you correctly, you need to reteach it. But you don't just repeat the same words louder, you try a different way.
Like using visuals. The text emphasizes visuals.
Absolutely. Maybe you draw a simple picture, maybe you color code the medication bottles, you use a video, you do a demonstration, and you have to remember the difference between how adults learn and how children learn.
Adults are problem-focused, right? They need the why.
Yes. Adults have to know the why. Why do I need to give this antibiotic for all 10 days if she feels totally better in 3? If you don't explain the why, about drug resistance, about the infection coming back stronger, they won't do it. Children, on the other hand, learn through play, through stories, and repetition.
So for Emma, you might play a hospital with her doll to teach her about her care. But for her mom, you explain the science behind the treatment plan, and then you use the teach-back method to confirm she gets it.
Precisely. You are tailoring the education just like you tailor every other part of the medical care.
This has been such an eye-opener. It's funny, we started with a topic that, on the surface, sounds like it's about being gentle, but we've covered more critical safety protocols in some of our more technical deep dives.
That's the absolute reality of pediatrics. The so-called soft stuff is the safety stuff. If you can't communicate effectively, if you can't gain trust, if you can't get a child to cooperate without terrifying them, you simply cannot provide safe medical care.
So let's bring it all back home. Back to Emma. She's on the unit now. You're the nurse walking into her room. Based on everything we've learned today, the pillars, the language, the developmental hacks, how does her admission go now?
Ideally, you walk in, you don't tower over her bed, you get down on one knee so you're at her eye level. You smile. You introduce yourself to her and to her parents. You use simple, non-threatening words. Hi, Emma. My name is Chris. I'm a nurse, and I'm here to help your head feel better.
No stretchers, no dye, no shots.
No, none of that. You say, we're going to take a little ride on a rolling bed so we can take some special pictures of your head to see why it's hurting. You give her a valid choice. Do you want to bring your teddy bear with you or your special blanket?
And when it's time for that IV start?
You use numbing cream if you have time. You call the child life specialist to be there to distract her with bubbles or an interactive book on an iPad. And you use therapeutic hugging.
Her mom holds her chest to chest.
Emma feels safe. She's anchored. She might cry a little bit because it's a pinch, but she isn't being held down and overpowered by strangers. She retains her dignity in the situation. And afterwards, she gets the red Band-Aid that she chose.
And her parents understand exactly what to watch for at home because you used the teach-back method before they were discharged.
That is atraumatic care. You took a scary, chaotic event, and you made it manageable. You did no harm. In fact, you did good.
It's powerful stuff when you see it all come together like that.
It really is. And if I can leave our listeners with just one final thought on this.
Go for it.
We talked about that 45% health literacy statistic. Now think about that number in the context of informed consent. In medicine, we are obsessed with getting the signature on the form.
Right. The paperwork has to be done.
But if we are rattling off a list of risks and benefits to a tired, stressed parent using a bunch of medical jargon, and we don't stop to check for their understanding, are they really consenting?
Or are they just submitting?
Exactly. Are they actually giving informed consent? Or are they just submitting to authority because they feel overwhelmed and don't want to look stupid?
Wow.
True atraumatic care isn't just about the needle. It's about ensuring that the family isn't traumatized by their own confusion. It has to extend to the parent's understanding, too. If they leave the hospital feeling empowered and capable, you've done your job. If they leave feeling confused and scared, the trauma just continues at home.
That is a mic drop moment right there. Are they consenting or just submitting? I think that's something every single clinician needs to ask themselves before they uncap a pen for a signature.
It's the difference between being a technician and being a healer.
Well, on that note, we're going to wrap up this deep dive. To all the learners out there, whether you're prepping for the NCLEX or just trying to be a better, more compassionate human, go out there and be the nurse who makes the hospital just a little less scary for all the Emmas of the world.
Do no harm.
Thanks for listening. We'll see you on the next one.